Okay, so thank you for being here today. ICER and the Midwest CEPAC are going to be discussing ensifentrine. It should be noted that at the beginning of every Midwest CEPAC meeting, we want to ensure that all speakers and members of the Midwest CEPAC disclose any financial relationships they have with industry. Every member of the Midwest CEPAC panel who's present today has met the ICER conflict of interest policy. And so I want to call on each of the members to introduce themselves, their work, and note if there are any updates to any of their conflict of interest statements. So I'll start. My name is Jill Johnson. I am a professor of pharmacy practice at the University of Arkansas for Medical Sciences. I'm a clinical pharmacist. I work on a lot of formulary committees, but I don't have conflicts of interest that need updating. So next, Bijan.
Hi, I'm Bijan Bora. I am a professor of health services research at the Mayo Clinic College of Medicine and Science, and I don't have any conflict of interest as defined in the ICER policy. Thank you all.
Don.
Good morning. I'm Dr. Don Casey, internal medicine specialist and associate professor of medicine at Rush Medical College in Chicago.
Albert.
Good morning. I'm Albert Huang, professor of medicine and public health sciences at the University of Chicago. I'm a general internist, and I study medical decision-making for older adults living with diabetes. I have no conflicts of interest.
Brad.
Good morning. I'm Brad Martin, professor in Division of Pharmaceutical Evaluation Policy at the University of Arkansas for Medical Sciences, and I have no new conflicts to report.
Jimmy.
Good morning. My name is Jimmy O'Hare. I'm a patient advocate. I suffer from sickle cell disease, and I had the good fortune of participating in a clinical trial that changed my life about 4 years ago. I have nothing to report, no new conflict of interest.
Tim Wilt.
Can you hear me?
Yes, we can.
Okay, great. Thanks. Sorry. I am Timothy Wilk, general internist at the Minneapolis VA, and I have no conflicts. Great. Thanks.
Stuart.
Good morning. This is a privilege to be here. I don't have any updates to my conflicts of interest, and I'm a clinically retired cardiologist who's working in the patient experience domain for a large multi-specialty practice, Trinity Health's IHA Medical Group, headquartered in Ann Arbor, Michigan.
Thank you. Rachel.
I'm Rachel Sachs. I'm a professor of law at Washington University in St. Louis. I study innovation and access to new healthcare technologies, especially pharmaceuticals, and I have no conflicts of interest to declare.
Okay. Tim McBride.
Good morning. I'm Tim McBride, and I'm the Bernard Becker Professor in the Brown School at Washington University, and I study health insurance issues related to Medicaid, Medicare, and the uninsured, and I have no conflicts of interest to add or that meet the standards set up by CEPAC.
Thank you. David.
Hello, I'm David Kim, Assistant Professor of Medicine and Public Health Sciences at University of Chicago. I'm a health economist focusing on measuring value of health interventions, and I have no conflict of interest.
Jayani.
Hi, I'm Jani Javadana, an associate professor in the College of Public Health at University of Kentucky. I study substance use policy research, and I have no conflict of interest to report.
Inge.
Yeah, hi, I'm Inge Falkeder. I'm a professor at Case Western Reserve University. I'm a hepatologist and a methodologist. Thank you. I have no conflicts of interest to report. Thank you.
Thank you. Kurt.
Good morning. I'm Kurt Vandenbosch. I'm a pharmacist with the St. Luke's Health System in Idaho, and I have no conflicts of interest.
And last but not least, Eric.
My name is Eric Armbrook. I'm a professor at St. Louis University School of Medicine. I'm involved in research and public health programming as it pertains to chronic disease management. I have no conflicts of interest. Thank you.
Thank you. We also have today some patients and some clinical experts. So I'll call on them to introduce yourselves and declare any potential conflicts of interest as well. The first one is Valerie Chang.
Hi, I'm Valerie Chang. I'm a retired attorney and lifelong never smoker, retired judge also. I have idiopathic severe moderate to severe emphysema, and I have no new conflicts to declare. Thank you.
And Phyllis DiLorenzo.
I'm sorry.
It's all right. Can you hear us?
I'm sorry. Good morning. I'm Phyllis DiLorenzo with the COPD Foundation, a patient advocate and board member. I'm a retired social worker. I've been diagnosed with COPD, emphysema, phenotype for 9 years, and I'm thankful to be here, and I have no conflicts of interest to declare.
Well, we are glad you're here with us too. Thank you both for being here. We also have two clinical experts. First one is Dr. Stephanie Christensen.
Hi, everyone. Thanks for having me. I am a pulmonary and critical care physician from UCSF, associate professor there, where I also do some clinical and translational research. I do actually have several conflicts of interest. I work with a lot of companies on study design for their studies and help them figure out how to get drugs to patients. But I do it for a lot of companies, so including Verona, but not specifically Verona. So I work with a lot of different companies on that.
And thank you for that. And Dr. Juan Rojas.
Hello, everyone. I'm also an adult pulmonary critical care doctor. I work at Rush University in Chicago. The only conflicts that are not on the screen now are some grant funding from the NIH and Robert Wood Johnson Foundation. Otherwise, no relevant disclosures that are new to report.
Okay, thank you. We also have a policy roundtable, and we would request that those participants and individuals who make public comments announce any financial relationships they have with industry or other potential influences on the judgment when they speak. So we will present this information on the slides as well as we have so far. Right now, I'd like to introduce Sarah Iman, who's the president and CEO of ICER.
Thank you so much, Jill, and thank you everyone for being here today. It's my pleasure to welcome you all to this convening of the Midwest CEPAC. I'm joined today by David Rind, our Chief Medical Officer, Mel Whittington, who's the lead economic modeler for this review, Grace Lynn, who is the lead clinical evidence author for this review, and Steve Pearson, ICER's founder and special advisor, who you'll be hearing from later as he moderates both the voting and the policy roundtable. Next slide. Every time we convene to talk about a new drug, we want to remember that even though many of us can get pretty wonky and into the details of clinical trial design and economic modeling, that we're here because there are patients that have an unmet need. And when we do our reviews, we start our reviews by talking to patients, patient advocates, and their families so that we can learn about the lived experience. This particular quote that we heard in the beginning of our review has really been a guiding principle for us as we conducted our research. They described living with COPD this way: I tire out a lot easier than I used to. I find that when I plan my day, I try to plan it for the mornings because I know by afternoon, I'm done. I used to have a very active lifestyle. I used to walk everywhere. I can't do that anymore. I've made many modifications around my home. I have chairs everywhere for support so I can move around without a walker. I want to get a ramp to the front door, mainly for carrying oxygen tanks in and out of the house. Speaking of oxygen, that's another thing I need to factor in when planning for my day. COPD rules my life. Next slide. So why are we convening today? We're convening today because there's a new treatment in the pipeline, potentially getting FDA approval. And beyond what the FDA will be looking at about safety and efficacy, there's a role to play to think about what we will do as a society with a new treatment. What are the risks and the benefits? How does this treatment fit into what we already do? How does it compare to existing treatments? And then take that further. How can we think about pricing it in a way that's reasonable for both patients and society? And at the end of the day, what lessons are we learning from this exercise of having a public dialogue about a new treatment that help guide future actions, like the development of new innovative therapies, the pricing of therapies in line with value, and thinking about affordability? Next slide. The reason that we do not shy away from talking about costs is that costs and increasing costs impact all of us. The stories are familiar to those who read the news. We know that more and more people are accumulating debt as they try to afford their healthcare. People like the Wards of Chicago, who went $80,000 in debt because their twins were born premature. Sherry Foy, who was forced into bankruptcy because she needed surgery to remove her colon. Or the Bucks of Arizona, who tried to seek care at their doctor's office, but were turned away because they had outstanding debt and then had to seek care in an emergency room. And more recently, the state of Delaware announcing that they were raising premiums for state employees 27%, mostly due to the rising cost of outpatient visits, emergency care, and specialty drugs. We highlight these facts because we all have a responsibility to think about the fairness of the prices we pay in a way that ensures affordable access for everyone. Because when we don't center those other people in the healthcare system, we can unintentionally harm them by these increasing costs. Next slide. So we think about that because while we all agree that in this case, we're talking about COPD with a new treatment that might be approved, we very much want to focus on the patient experience, what the patient and the doctor will be thinking about with this new treatment option that could become available. But we also have to remember all of the other people in the system who are impacted by the decisions that we make about price and access. Next slide. All right, so to orient everyone to some of the acronyms we've already been using, we are ICER, the Institute for Clinical and Economic Review, an independent nonprofit. We convene our Midwest CEPAC, an independent appraisal committee made up of experts in clinical evidence and evidence-based medicine, health economics, and patient and consumer perspectives. That Midwest CEPAC is independent of ICER and will be here to keep us honest about the conclusions of our clinical review and our economic modeling. And then we'll vote on the actual evidence to inform future policies around this new treatment. Next slide. We like to be very transparent about where our funding comes from. All of our research is funded by nonprofit foundations and other philanthropy, the largest of which is Arnold Ventures. We also get money from the California Healthcare Foundation and the Commonwealth Fund. When we do take money from manufacturers, health plans, or provider groups, it's only to support the activities of our policy summit, where we bring leaders from those organizations together in a dialogue to try to tackle some of the biggest issues we're facing from a policy perspective. Most recently, how to pay for gene therapy is a little bit of a plug for the report we just did with them that came out just a couple of months ago. Next slide. So for those following along at home, feel free to go find the evidence report on our website that'll be the basis of the conversation today, and a little bit about how that's developed. we start out by saying, what are the research questions that we're trying to answer from a comparative clinical effectiveness perspective? And we do that by talking to patients, clinical experts, advocacy organizations, the manufacturers in scope, and any other stakeholders that might have a relevant perspective. In this case, we partnered with an evidence author, Grace Lin from the University of California, San Francisco, and a leading health economist, Mel Whittington from Tufts Medical Center, to contribute their expertise to the development of this report. We seek public comment, and then we revise based on that public comment. We even respond to all of those public comments. That can be fun reading if anyone's interested. All of those responses to public comment are also available on our website. We're also deeply thankful for the input of our expert reviewers listed here, none of whom should be assumed to approve or endorse any part of the ICER report, which is solely the work of ICER and its research partners. So as you're following along at home, that report will go through the background of the condition and the treatment landscape. We'll have a chapter that talks about the patient and caregiver perspective so that we're always grounding conversations about evidence in that lived experience. There's an entire section on the comparative clinical effectiveness where we're talking about what the evidence shows us for these new treatments. And then that's translated into an economic model that helps us answer critical questions about the long-term cost effectiveness and the long-term value of these therapies. We have a section that talks about benefits beyond health and special ethical priorities, and a section that talks about the fair price range for these drugs and any potential budget impact we may be wanting to watch as policymakers with the introduction of a new therapy. Next slide. You can click thank you. And one of the things to think about as you're hearing the conversation today is when we think about long-term value for money, we have an extensive value assessment framework that helps us analyze that, which is available on our website. But just as a reminder, what are the elements that we're talking about? We're talking about how much better patients feel on this drug, whether there's any life extension, if the condition happened, it has an impact on life extension, and what are the overall costs and cost offsets associated with this therapy. The stuff in green there makes up the economic model. The stuff in blue is also critically important and is important for policymakers to consider as they think about where these treatments fit in the treatment landscape. What does the fair price look like, considering these other special ethical priorities and benefits beyond health? And we'll even have some particular voting questions that get at this today later on. Next slide. You've made it through the opening remarks. Congratulations. We'll be turning soon to Grace Lin, who will be looking at and presenting the clinical evidence, followed by Mel talking to us about the economic model. We'll take some public comments, have a discussion. After a break, the Midwest CEPAC will deliberate on the evidence and cast their votes about what the evidence tells us from a clinical and value perspective. After another break, we'll convene some experts to talk about what we do now with what we've found with the evidence. What does this mean for evidence-based policymaking as we try to, again, root a conversation about evidence and value in the decisions we make about price and access. Following some reflections from our Midwest CEPAC, we will be adjourning today at 4 o'clock Central Time. With that, it is my absolute pleasure to introduce Dr. Grace Lin, who will be taking us through the evidence presentation.
Thank you, Sarah. Good morning, everyone. As Sarah says, I will be starting off the day giving you an overview of the clinical evidence for ensifentrine. Next slide, please. This report and presentation wouldn't have been possible without my outstanding collaborators at ICER, including Abigail Wright, Avery McKenna, and Finn Raymond. And our disclosures are listed there on the slide. Next slide, please. So give you a landscape of COPD. COPD, as many of us know, is a group of lung diseases that is characterized by progressive and persistent airflow obstruction in the lungs. It affects about 16 million people in the United States and is the 6th leading cause of death. Smoking is the leading cause of COPD in the US, although with smoking rates decreasing, other factors such as secondhand smoke exposure, occupational exposure, and chronic asthma can play a role as well. COPD is a costly disease. It leads to 1 million emergency department visits and 50,000 hospitalizations per year, and results in a cost of at least $50 million in direct medical care. Next slide, please. The diagnosis of COPD is based on lung function. You'll hear me talk about forced expiratory volume in 1 second, or FEV1, and forced vital capacity, FVC. And the diagnosis is based on a ratio of an FEV1 over FVC of less than 0.7. Symptoms include persistent shortness of breath, fatigue, wheezing, chest tightness, sputum production, and cough. And exacerbations, which I will talk about in a few slides, are also an important marker of the disease. Next slide, please. So the classification of COPD is based on the severity of airflow obstruction, and that's that FEV1 measurement. Risk of exacerbation, and that's the number of exacerbations per year, and the severity of symptoms. So you can see on the right here, this is the GOLD ABE assessment tool, which is this international standard for classifying COPD. And you can see that based on FEV1 there in the center, you can have a GOLD classification of 1 through 4, which corresponds to normal, mild, moderate, and severe COPD. I'm sorry, it's severe and very severe COPD. And then based on your exacerbation history, whether it's greater than 2 moderate exacerbations or 1 leading to hospitalization, which is considered higher risk, or 0 to 1 considered lower risk. And then your symptom based on the a scale, for example, the Modified Medical Research Council scale or the COPD assessment tool. Put those things all together, and that's how COPD is classified in terms of mild, moderate, or severe. Next slide, please. So we were fortunate enough to have discussions with people with COPD, including Valerie and Phyllis, who you'll hear from today. And what they told us was that the COPD has a great impact on daily life. Their daily tasks are challenging. For example, just even making the bed sometimes can be challenging. They need to plan around symptoms. They told us that you need to pace yourself because otherwise you'll run out of energy and not be able to complete tasks. Travel can be difficult, even just going outside the house, particularly if oxygen tanks or wheelchairs are required. They told us that treatment is complex, that there are potential side effects to the treatments like dry mouth, diarrhea, cough, and headache that can be difficult to manage. There can be, they need to manage multiple inhalers and nebulizers and may have some difficulty with proper inhaler technique to get the full amount of medication. And having a nebulized treatment can be time consuming and less portable than inhalers. COPD provides a burden on unpaid caregivers. Caregivers monitor adherence and bear the burden of physical and emotional support as the disease progresses. They also told us for future treatments, what they would really like are disease-modifying treatments, as there are no drugs that are disease-modifying at the moment. And they would like treatments that decrease mucus production and the need for supplemental oxygen. Next slide, please. So when we talk about COPD treatment, we have non-pharmacologic treatments and pharmacologic treatments. In terms of non-pharmacologic treatments, smoking cessation and pulmonary rehabilitation are key pillars of non-pharmacologic treatments. In terms of drugs, what we have are mainly inhalers, long-acting beta-2 agonists or LABAs, long-acting muscarinic agonists or LAMAs, and these can be with or without inhaled corticosteroids. You could have dual therapy, which is dual LAMA plus LABA therapy, either 2 inhalers or they have combination inhaler with both of those drugs, or triple therapy, which is the LAMA, LABA, and inhaled corticosteroid combination. There's also a phosphodiesterase 4 inhibitor called roflumilast. It's oral drug. And then the antibiotic azithromycin may also be used in COPD treatment. Next. About half of COPD patients report near daily symptoms, and the majority reporting symptoms that the symptoms have a moderate to great impact on everyday life. So even with all the available treatments that we have, there's still a need for new treatments. Next slide, please. So that brings us to ensifentrine. This is a dual PDE3 and PDE4 inhibitor. And what inhibition of PDE3 and PDE4 does is that it relaxes the airway smooth muscle. It works as an anti-inflammatory and helps clear mucus by improving ciliary function. Next slide, please. So for our review, the population of focus is adults with moderate to severe COPD. And we conducted a comparative clinical effectiveness of ensifentrine as an add-on therapy to current maintenance therapy. And by current maintenance therapy, we include LABAs, LAMAs, inhaled corticosteroid, or any combination of the above. And we're comparing this to current maintenance therapy. Next slide, please. In terms of outcomes that we looked at, we focused on the annualized moderate or severe exacerbation rate. Remember, a few slides ago, I said that exacerbations are an important part of classifying COPD, and we can classify exacerbations as moderate, which is defined as a worsening of symptoms for more than 2 days, requiring systemic corticosteroids and/or antibiotics, or severe, in which your symptoms require inpatient hospitalization. We also looked at quality of life measures, including 3 standard measures for COPD, including the Transition Dyspnea Index, or TDI, the Evaluating Respiratory Symptoms Scale, ERS, or the St. George's Respiratory Questionnaire. We also had some data on the EQ-5D-5L, General Quality of Life Scale. The primary outcome of the trials were lung function measures, including change in FEV1 from baseline. And then we also examined time to first exacerbation, and there was also some data on daily average rescue medication. Next slide, please. So delving a little into the clinical evidence, we had evidence from 2 phase 3 randomized clinical trials called ENHANCE-1 and ENHANCE-2. These were both double-blind, placebo-controlled trials of approximately 800 participants each. The participants were all adults with moderate to severe COPD, and follow-up was 24 weeks, with a subset in ENHANCE-1 being followed to 48 weeks. Next slide, please. So in terms of the participants in the trial, they were able to be on rescue medication like albuterol or salbutamol, and they were as maintenance therapy, they could be on either LAMA or LABA therapy, and with addition of inhaled corticosteroid if needed. So the LAMA-LAMA combinations, or dual therapy and triple therapy with LAMA-LABA ICS, were not included in the trial. You could not be on oral or systemic or parenteral steroid therapies. You couldn't be on a very high dose of inhaled corticosteroids or antibiotics for respiratory tract infection. And there's some limitations on some other drugs within a few hours prior to some of the measurements being taken, so that in order to see the effects of ensifentrine. Next slide, please. In terms of baseline characteristics, the trial populations had a mean age of around 65 years old. They were predominantly white and male participants. About a little more than 60% were on background therapy. It's, as you can see here on the slide, most were on either LAMA or LABA monotherapy. About 20% were on inhaled corticosteroid, and about a quarter had an exacerbation within 15 months prior to entering the trial. I want to note here that trial withdrawal was unusually high from what we usually see in large randomized controlled trials. And this was primarily because the ensifentrine trials had the portion of being conducted during the COVID pandemic in basically 2020 to 2022. The trial, you can see that the withdrawal was between 15 and 23%, depending on your trial. Some of those people were dropped out because of COVID, and they were required to drop out if they acquired COVID, and others may have withdrawn for other various reasons related or not related to COVID. Next slide, please. So in terms of results, we did a meta-analysis of pooled data from both ENHANCE-1 and ENHANCE-2 trials, and that showed a statistically significant 40% decrease in the annualized event rate of exacerbations at 24 weeks compared with placebo. This is the primary outcome that's used in the economic model. So you'll hear Dr. Whittington mention exacerbation rates when she's doing the presentation of the economic model. Next slide, please. Ensifentrine also increases the time to first exacerbation, so delays that first exacerbation once you start the drug. And again, this is our pooled estimate that showed an overall 40% hazard ratio, or 40% decrease in time to first exacerbation. This benefit was maintained at week 48 for participants in ENHANCE-1 who were followed to the 48-week time point. Next slide, please. The effect of ensifentrine on quality of life was somewhat inconsistent. Here you see that mean changes versus placebo did not exceed the minimal clinically important difference for 2 out of the 3 quality of life measures, and that's the mean change, mean difference from placebo. However, another way to look at this is you can look at the proportion of patients who reached or exceeded MCID in the ensifentrine group as a measure of how many responders there might be. And for the ERS and the St. George's Respiratory Questionnaire, a greater proportion of patients in the ensifentrine group reached or exceeded MCID at 24 weeks. For the transition dyspnea index, the mean change in TDI exceeded MCID in ENHANCE-1 only. In ENHANCE-2, it did not. And when we looked at the data for the EQ-5D, which was only measured in ENHANCE-2, there was a statistically significant improvement in the EQ-5D measure. Next slide, please. A couple of other outcomes. As I mentioned, the primary outcomes of the trials were a change in FEV1, and the ensifentrine groups had significant improvement in FEV1 at 12 weeks in ENHANCE-1 and 2. There was also a measure of how much rescue medication you needed daily. We pooled data from ENHANCE-1 and ENHANCE-2 at 24 weeks, and ensifentrine decreases the use of rescue medication at 24 weeks. Next slide, please. In terms of harms, ensifentrine has actually a relatively good safety profile. There was similar reporting between ensifentrine and placebo arms for serious adverse events. Discontinuation because of adverse events was similar between the 2 groups. Gastrointestinal harms, which are more prominent in the oral form of the PDE4 inhibitor, was a fairly low rate for the inhaled form. And other harms like pneumonia, which you worry about with inhaled corticosteroids, hypertension, cardiac events, all of those were a very low percentage. Next slide, please. Some controversies and uncertainties when we look through the data. So we want to just highlight that the demographic differences in the trial, there were demographic differences in the trial compared to real-world patients. The trial patients were younger and had fewer exacerbations. And then importantly, background therapy didn't reflect current standard of practice. Now, it's important to note that back in 2020 and prior to that, when the trial was planned, standard of care therapy included just LAMA or LABA with or without inhaled corticosteroid, which is what you saw in the trial. Since then, there's evidence that LAMA combination therapy or triple therapy with corticosteroid is more effective. And so that is, that is the current standard of care, and that wasn't included in the trial. Also importantly, 30 to 45%, depending on the trial, were on no background therapy at baseline. There was some heterogeneity in results between the two trials on quality of life. As I mentioned earlier, 2 out of 3 quality of life measures didn't exceed the minimal clinically important difference. And similar changes, there were smaller changes in the ENHANCE-2 trial. There was also short trial follow-up and a high withdrawal rate. The primary outcomes were measured at 12 and 24 weeks. There are other COPD trials that have extended to 52 weeks. So these are relatively short-term outcomes. And then, as I mentioned, of the high withdrawal rate that was likely affected by the pandemic. And this can affect both a power issue and potential bias. It's possible that people who are doing better are less likely to drop out due to fear of COVID. And so, you could have a bias in the direction of people dropped out because they were, they had COVID. So you could bias in either direction. Next slide, please. In terms of benefits beyond health and special ethical priorities, so as I mentioned, there's an unmet need for COPD since many patients are still symptomatic even on therapy. So this ensifentrine may be particularly valuable in patients who have suboptimal disease control. They continue to experience symptoms or have side effects on therapy. This ensifentrine is not thought to be disease modifying though, and so probably would not have a large effect on patient or caregiver ability to achieve long-term goals. And we don't think that there's a great impact on access with ensifentrine since it's delivered via nebulizer, which many patients already are on some form of nebulized treatment. So that wouldn't necessarily have much of an impact. Next slide, please. We appreciate the public comments we received on our report. And what we heard was that the symptom burden associated with COPD is significant, and there is an unmet need for newer treatments. We also heard that the quality of life measures do not capture the full spectrum of impact of COPD, that they measure respiratory symptoms, but they don't necessarily measure the impact of the respiratory symptoms on someone's life activities. Next slide, please. So in summary, ensifentrine improved measures of lung function, including average FEV1 at 12 weeks. It also decreased the annualized rate of moderate to severe exacerbations by 40% at 24 weeks. This was maintained until 48 weeks in ENHANCE-1. The evidence of the impact on quality of life was mixed. The adverse event and discontinuation rates were similar amongst both the ensifentrine groups and placebo and were relatively low across the board. And the efficacy of ensifentrine in the long term and for patients on dual or triple therapy needs further study. Next slide, please. So all of this leads us to the evidence rating we gave ensifentrine. And so again, this is ensifentrine added on to maintenance therapy compared with maintenance therapy alone. And we, after reviewing the evidence and discussion, we gave the ensifentrine an evidence rating of B+, which corresponds to at least a small net health benefit, we believe, and this treatment with ensifentrine may result in a substantial net health benefit. We have somewhat greater certainty in these benefits when ensifentrine is added to the regimen studied than to dual or triple therapy, which was not studied in the phase 3 trials. There is some phase 2 data that suggests that ensifentrine on top of triple therapy and dual and triple therapy it may be effective, but again, those are phase 2 earlier phase data and not the phase 3 trial. So that concludes my review of the evidence, and I'm happy to take questions. Thank you.
Okay, I guess I'll call on myself first. Thank you for that presentation. My question is, how did ICER arrive at a B+ with the uncertainty that we have, because we've got a run-in also that I don't know if you mentioned, but that provides a level of selection bias. And then we have a large dropout. We have comparisons to what we're not using now. So why B+ and not like C+?
Thank you. That's a good question. I'm going to walk through our thinking, and then I'll also perhaps our clinical experts can also add some context. So when we looked at ensifentrine as a whole, with all the caveats that you mentioned, we felt like it's a different mechanism of action. And based on the phase 2 data and the fact that the oral PD for roflumilast is added on to dual or triple therapy is effective, we felt like there's a reasonable probability that there would still be some effect even on dual or triple therapy, although we don't know how large that effect is, which is why the B+ with the small to substantial net benefit. We also looked at the harm, the relative risks and the relative harms, which were very small. So when we talked to patients with COPD, they told us, some of these side effects, I can't take, or I can't tolerate these side effects. And so a drug that has minimal side effects is also an advantage. In terms of the withdrawal rates, they were high, but because they were due mainly to COVID, we don't think that there was much bias there. And then we also took a look at subgroups, which I didn't present in the presentation, but in terms of the subgroups, did not seem to be any effect modification based on subgroup and including background therapy. So it didn't matter which background therapy you were on, it seemed like you had a similar effect. So based on all of those factors, we came to the conclusion that of the B+ rather than the C+. Now, we do note that we're more confident in adding the addition of ensifentrine to the regimens that are studied, but we do see some evidence that it likely would be beneficial added on to current standard of care. I will also ask our clinical experts if they have any comments, since they probably have thought about this quite a bit. Dr. Rojas or Dr. Christensen?
I don't know who wants to start. Yeah, I guess I would agree sort of with some of the things that Grace mentioned around, I guess, some of the limitations in the trials in relation to both the COVID dropouts and also, I guess, that this shifting of standard of care. I think in clinical practice today, I think, this drug would be a potential option for a lot of my patients I care for in my clinical practice who are sort of optimized on dual or triple therapy, yet have either more frequent exacerbations than they would like, and or have potentially a decrease in quality of life even if they're not frequently exacerbating, where this drug could potentially have a role as additional adjunctive therapy on top of the mainstay inhalers. And to Grace's point earlier around nebulized therapy access, the vast majority of, I would say, my patients in my own clinical practice already have a nebulizer machine for some rescue therapies. And so the additional burden on a patient to sort of get that device would be pretty limited, I think, for the patients who would probably be prescribed this drug. And so, yeah, I think those are all, great points that Grace made in regards to how this might impact real world clinical practice.
Thank you. Tim Wilt.
Thank you. I want to echo a lot what Jill just said, but to kind of highlight that a little bit more, maybe one of the things to add would be, we've heard that several of the patients, different mechanisms of action, several of the patients mentioned harm from others, the drug, so they can't tolerate them. So then really the question is shifted. It's in those not who are on optimal baseline therapy, because it appears that they have not been. But the question should really be in those who are intolerant or who are not on optimal baseline therapy. And I would agree completely with the comments in the chat. Exacerbations can be really devastating to patients, caregivers, et cetera. That appears to be where this drug has any effect in the quality of life and exacerbation period among those who are exacerbation prone. But it does not appear to have overall improvements in respiratory quality of life, et cetera, in the average individuals. And the use of nebulizer therapy on a daily basis is definitely different than periodic exacerbation prone 1 to maybe 5 times a year use of nebulizer therapy. So I think it's really the data are a shade shy of convincing that it adds at least small to moderate net benefit. Thanks.
Thank you. Albert.
Can I just jump in? I know that Dr. Christensen didn't get to answer before,
Certainly.
and maybe wants to answer either Dr. Wilt or the other.
Yes, that's why I had that is why I have my hand raised. I think, you know, I really agree with Dr. Rojas' statement that, okay, you know what, this clinical trial is somewhat problematic in that it's probably not how we're going to completely use this drug. And the guidelines, as Grace mentioned, really changed between 2022 and 2023, where we now use LAMA-LABA for our symptomatic patients. Although that's what GOLD recommends. It's not necessarily what everybody's doing. In fact, we still have a lot of people coming to us on ICS LABA as a pulmonologist. That's very common, or just on one inhaler alone. So that's also very common. I think one of the other points, though, is that we can somewhat extrapolate from our experience with roflumilast, because we've had that drug on the market for a really long time, and it's got a similar mechanism of action with the PDE4, although this has PDE3 and PDE4. And roflumilast can really, really work in a subset of patients. So if you tried it enough, you would notice that it's that like a subset of patients are real responders, where they where this drug really, really works. And there's a lot of people who are not responders. So like me seeing, that there's like a group that are may have really good symptom control, and then there's a lot of people who don't, really goes along with like the heterogeneity of phenotypes in our COPD patient population, where some people have either a lot of smooth muscle activation and can get a lot of air trapping, and we can maybe help alleviate that, or may have a lot of mucus production, which some of these PDE inhibitors supposedly help work with. So, and some of that mucus production is actually related to air trapping. It's not that people all have chronic bronchitis. Some people just have a lot of stuff that can be stuck in there. So we can it's not always super obvious who might actually have a symptomatic benefit, but if you try enough people, you may notice that. The problem with roflumilast and azithromycin, our current add-on therapies, are that they have a lot of side effects. In particular, roflumilast has some real substantial side effects. So in patients who have frailty, or we really just, like, if the goal is really to try to improve your quality of life, and I'm going to give you horrible GI side effects, well, I don't want to do that. And if I'm going to make you lose weight, I really don't want to do that. So we don't try it in a lot of patients. Or we don't use it in a lot of patients. In fact, we don't even try it in a lot of patients. And I think that's pretty common that roflumilast doesn't have a lot of uptake. And even azithromycin, where we do use that drug in former smokers a lot, it's got problems with arrhythmias, problems with hearing loss, and problems with antibiotic resistance. So some of these other add-on therapies we get very nervous about. So having another add-on therapy, even if it's we're not exactly sure completely where to place it, but could potentially help a lot of our patients where we don't have all those side effects, is potentially actually could be really beneficial. And it's one of the reasons I'm very interested in this drug, that we could possibly try it in people, and hey, if it doesn't really help, we can take it away. But if it's really helpful for you, it's got a minimal side effect profile and could be really helpful. Sorry, that was a long answer, but I just wanted to make sure we brought up some of those points.
Thank you for that. I don't know, the public can't see all of the comments, but Dr. Rojas also agreed that GI side effects with roflumilast are a concern. So that seems to be a trend. So Elbert.
Hi, it would really help me, I think this question is for Grace, to understand where this this new drug would fit, and maybe the clinical experts as well. I would love to know about general trends in COPD exacerbations. Is it going up, down? Is it flat? And then from a population perspective, how big is the population that is suboptimally managed currently with double or triple therapy, like just not using it, and could benefit from existing drugs, versus people who are already maxed? What's the size of the population that would be candidates for this drug?
Thanks for that question, Dr. Huang. So, yeah, as I mentioned in my talk, there was a survey of patients that estimated 50%, almost 50% of patients would continue to have daily symptoms even when they were on therapy. So, there's a potentially large population that continues to have symptoms despite therapy. In terms of exacerbations and I think it's sort of funny. I think the trends are sort of, you have to take them with a little grain of salt because it was COVID, and I think COVID changed behavior, and so you saw less exacerbations because people's behavior changed. They were wearing masks, they didn't go out necessarily. So I'm not sure if we can actually take the last few years and as an accurate trend. But I'll defer to Dr. Christensen and Dr. Rojas on that. There's sort of mixed. There's sort of controversy about how many people are on dual versus triple therapy, because there are also, when you look at some of the numbers, there are also these combinations, single inhaler combinations of dual and triple therapy. And so when you do the counting, is that one inhaler? Is that three inhaler? So that when you see some numbers, it's not always clear how many people are on which therapy. And so, the numbers I have seen, although these are older numbers, so with the change in guidelines, I think there's still a lag in terms of numbers. I don't know how many people are on. It was a small percentage that were on dual or triple therapy, under 10%. But I suspect that those were older numbers, I think from 2022. So I suspect that will have changed. And Dr. Christensen and Dr. Rojas may have a better real world idea of the real world at this point.
I mean, I'll say some, I'll go first just, and then Dr. Rojas can chime in, but I agree that during the pandemic, our exacerbations rates went down. Kind of interesting for us as they kind of popped back up again into the range where we see them anecdotally. But I think some of that bore out over with the data that exacerbations rates went down, which is kind of interesting to think about, that viruses may play more of a role in exacerbations than we even thought before, or also people potentially not going out and moving as much could have been an issue too. But at least anecdotally, we're certainly seeing that the rates are going back up to kind of what we normally see. And so as groups or as people go back out into the world, we're seeing more exacerbations. And certainly as we see, maybe smoking as we see the group of COPD patients growing, and particularly in where we may be diagnosing it more in low and moderate income countries around biomass fuels, that those groups are we may have more issues in those groups too, where we might see larger and larger groups of COPD patients. But I think that one of the you know, I think I also saw a comment in here about the low rates of people from underrepresented groups, which is very unfortunately common in some of these add-on therapy trials in COPD, where we're now kind of extrapolating, particularly in African populations, like what to do with them. That's the same for the biologics, which you guys might be discussing next year at one of these ICER discussions, but we certainly see in some of these underrepresented groups that exacerbation rates could be higher, particularly if they don't get as much access to care. So they're not, so we may not get to them as quickly, or they may have other exposures that could make exacerbations more common, like they're exposed more to like air pollution from living in the communities that they live in. So I think that those are just other potential considerations that yes, this could affect underrepresented groups disproportionately to because of some of those issues.
Yeah, I'll echo the same points. I think that to sort of answer a couple of the other questions I'll propose, yeah, I think exacerbations were lower now back to sort of my recollection of anecdotal historical trends in clinical practice. And then as far as how this might be used, I think in clinical practice, I think it really will be someone who is still having at least one or more moderate or severe exacerbations per year, despite being on, I guess, you know, gold recommended dual or triple therapy, probably triple therapy at that point. And then, you know, I think those are the patients I think who probably would be prescribed this. And I think, like we already spoke about, I think our reluctance with the additional adjunctive therapies were, you know, right now in my clinical practice, I think in many other pulmonary clinical practices, zithromycin definitely is used more, I think, than roflumilast, primarily because of the GI side effects. This drug may allow us to sort of try this mechanism of action with less, you know, concern around frailty or GI side effects, or sort of having, you know, that big barrier that I think a lot of patients were concerned about when they read about the side effects, or we were concerned about because we saw the patient and they were like 95 pounds, you know. So it's sort of, you know, the eyeball test didn't pass really for trying something that might cause them to eat less. And so this would be, I think, for me in my clinical practice, really be someone that is still having exacerbations, that has, you know, moderate to severe COPD, and is not, despite being on what we think is optimal inhaled therapies, not having the outcomes they want, and we want together. So
Thank you. I think we have time for like two brief more questions. So I'll call on Brad and Jimmy, and then we'll wrap things up for the next presentation.
Okay, I'll try to make this quick. So was there given any consideration in conducting an indirect treatment comparison with the trials that compared dual therapy to the monotherapy with this? And then, you know, I looked, I didn't see any that were published, not surprisingly, but wonder if the clinicians could kind of comment on what they think the added response rate, and particularly on the front exacerbations, how it might compare to dual therapy, yeah, adding this drug to dual therapy on that. So I know it's speculating, but I guess the first might be easier with an indirect treatment comparison, you know, considered, and then, you know, we don't have that, what might be the effect compared to what is contemporary management.
Yeah, thank you for that question. I'll answer that. We did not, you know, we considered, but ended up deciding not to do an indirect comparison, in part because, you know, it's difficult to find trials that would have had the appropriate data for us to do that comparison. So it was pretty out of the scope of our review.
Thank you, Grace. How about Jimmy?
My question is more of a general COPD question for the clinical experts, maybe the patient experts as well, and the panel. If smoking is the #1 cause of COPD, do any of you know if cigarette manufacturers, particularly nicotine-based manufacturers, are involved in any research and development for COPD therapy?
I can sort of answer that question. I mean, I think probably the particularly in Europe, people will think of the use of vaping and other such tools as kind of a smoking cessation device that you can use that to stop smoking, which is true. It just, they have really high nicotine concentration, so you may just develop a new addiction, and we don't really know what to do with some of those things. So that is certainly a place where people where the manufacturers, the cigarette and vaping companies are positioning things now. I will say a lot of companies and certainly researchers, we don't interact much with the tobacco industry. In fact, we are asked every time we present, do you have any interactions with the tobacco industry? So it's very much shied away from, probably appropriately. So that is one point there. I will say, and I'm just looking at some of the questions in the chat too, around study design. And I agree, it's a little, some of the study design issues where you had a lot of patients like not on therapy or on therapy where it was LAMA or LABA. I will say I would certainly put a person on a LAMA. I myself would certainly put a person on a LAMA and a LABA before trying ensifentrine, as long as they tolerate it. Not everybody tolerates both those drugs, but just because there's a much better evidence there. But for me, I'm like, maybe extrapolating a little bit from the roflumilast data is that there's certainly a lot. Well, extrapolating from all of the data would be that there's certainly a lot of people that still on those drugs have a lot of continued side effects. And there are definitely groups where adding an inhaled corticosteroid on is not really thought of as a great additional add-on therapy, particularly if you have EOs less than 100 or you have high rates of pneumonia. So, and extrapolating a little bit from the roflumilast data, where we know we tend to add that on as kind of a last ditch, where we add it on, after we've done a bunch of other things. So we'll often say, so it does work in some patients despite that. The other thing I think I would note for, even though, you might get better benefit if you add this onto somebody who's got less therapies, I will say this patient population, if you look at it overall, was a pretty, had lower rates of exacerbations, and so seemed to be a milder group than what we think of for some of these, like the triple therapy studies, where their exacerbation rates were only in like the 0.2 to 0.4 range, where in some of the triple therapy studies, it's more in the like 1.2 range. So it's so they were also a less symptomatic group, but I think that makes it both so dual-edged sword, but so it's hard to know how to exactly extrapolate. I think some of this would have to be real-world data that we'd have to get.
Okay, thank you for that answer. I think right now we should probably move on to the presentation of the evidence for the economic modeling. And so I'd like to introduce Dr. Mel Whittington. She's a senior fellow, Center for the Evaluation of Value and Risk in Health at Tufts University in Boston. Mel?
Thank you, and thanks everyone for being here today. I'm Mel Whittington. I led the cost effectiveness analyses within this assessment and look forward to presenting this economic evidence to you all. Next slide. I first want to acknowledge Dr. Marina Richardson, Associate Director at ICER, who led the budget impact modeling within this assessment. Next slide. The objective of this portion of the assessment is to evaluate the lifetime cost effectiveness of ensifentrine added on to current maintenance therapy compared to current maintenance therapy alone for the treatment of COPD in patients with moderate to severe COPD at baseline. Next slide. Now, to characterize the unmet need of COPD, we calculated the absolute and proportional shortfall, and those are the estimates that are presented on this slide. Now, the absolute shortfall, which is the value in the middle column here, represents the amount of future health patients with COPD are expected to lose under current standard of care. That for COPD was 8.1 EVO lives. So as compared to the general population, patients with COPD under current standard of care have 8.1 fewer EVO lives. The proportional shortfall, which is on the far right-hand side of the screen, represents the proportion of the total remaining health that is lost due to COPD under current standard of care, and that was 54%. Now, shortfalls can be challenging to understand, to interpret as standalone measures, and thus we provided shortfall estimates for 3 other conditions on this slide to provide context to aid in this interpretation. So you can see those here for multiple sclerosis, PTSD, and osteoporosis. Now, I'm interpreting shortfall estimates, particularly proportional shortfall estimates. It's helpful for me to have an idea of the age of that baseline population model. So for COPD, the average age was in the mid-60s. Multiple sclerosis and PTSD were younger populations in the upper 30s. And then osteoporosis was an older population in the early 70s. Next slide. I'm going to present on the methods in brief, but I hope you all have checked out our full report posted online that has much greater detail. But briefly, we created a Markov model from the United States setting. We took 2 different perspectives, the healthcare sector perspective and the modified societal perspective. We present the healthcare sector perspective as the primary analysis and a modified societal perspective as a scenario analysis. So I'll speak more to that in a coming slide. The time horizon was that of a lifetime, with all future costs and outcomes discounted at 3% per year. The cycle length was 1 year, and the outcomes included costs, quality adjusted life years, equal value life years, and exacerbations. Next slide. This slide reports our model schematic. As you can see, represented by each oval, the model had 4 primary health states defined by COPD severity based on the GOLD classification. And then there was a 4th health state defined by death. Members of the model cohort could only transition to more severe health states due to the progressive nature of COPD. All patients remained in the model until they died, either due to all-cause or COPD-specific mortality, which I'll speak to more in an upcoming slide as well. Next slide. Now, within each severity health state, within each of those ovals that were presented on the previous slide, exacerbations were tracked as events. And exacerbations were defined based on the healthcare utilization required. So a moderate exacerbation was an exacerbation that led to a prescription of a corticosteroid and or an antibiotic, but did not result in a hospitalization. And then a severe exacerbation was an exacerbation that did lead to a hospitalization for COPD. Exacerbations did have downstream implications on mortality, quality of life, and costs. And because they were modeled as events rather than as separate health states in the economic model, an individual could experience multiple exacerbations within one model cycle. Next slide. This slide presents the baseline characteristics for the population that entered the model. Baseline demographics were from large US registries or US claims data rather than from the trial to be actually receive this treatment in the real world. Looking at the bottom of this table, you can see the majority of the cohort started in moderate COPD, with about 80% of the cohort starting in moderate COPD, with the remaining starting in severe COPD. But over the lifetime time horizon, individuals in the cohort could progress to some more severe health states. Next slide. I want to first discuss a few of the key assumptions that will be important to consider when interpreting the findings. Starting at the top, we assume that ensifentrine's effect on lung function did not translate to health state changes, as ensifentrine is not expected to be disease modifying. So if you think back to a few slides ago where I showed the schematic that had the ovals and the arrows, the transition probabilities assigned to those arrows were the same in the arm of the model that received ensifentrine and the arm that did not receive ensifentrine, as ensifentrine is not expected to be disease modifying. In the middle on this slide, ensifentrine's effect on improved quality of life was downstream of its effect on exacerbations. So by preventing exacerbations, ensifentrine could improve quality of life, but we did not assume ensifentrine had an effect on the day-to-day quality of life of patients treated, but rather was linked to the prevention of exacerbations. We do test this assumption in a scenario analysis. And on the bottom of this slide, we assume that adverse event related discontinuation occurred at week 12 and only impacted the percent receiving the treatment cost. And that was because the effect size was not adjusted due to the intent to treat nature of the evidence. Next slide. This slide reports the total number of exacerbations per year for current maintenance therapy alone that were used in the model. So if you're looking at the second column, we have the total exacerbations per year, and you can see that number increases as the COPD severity increases. And looking at the two rightmost columns, you can see the severe exacerbations and the moderate exacerbations per year for each of these moderate, severe, very severe COPD health states. Now, importantly, the severe exacerbations per year represent 14% of the total exacerbations per year, with the remaining 86% being moderate. So the number of severe exacerbations per year, the number of moderate exacerbations per year do go up as the severity of the COPD increases, but the relative percent that are moderate versus severe is consistent. Next slide. We did model a treatment effect of ensifentrine on exacerbations using the exacerbation rate ratio of 0.6 in our base case analyses. This was from ICER's meta-analysis of ENHANCE-1 and ENHANCE-2 at week 24 that Dr. Lynn spoke to. This ensifentrine rate ratio was applied to the total exacerbations per year that were reported on the slide previous to this one. That relative percentage of total exacerbations that were severe being 14% versus moderate being 86%, that did not differ between the intervention and comparator arm. So this rate ratio was applied to the total number of exacerbations, and that split between severe and moderate was consistent between both arms. Next slide. The model accounted for COPD mortality in two different ways, related to exacerbations and not related to exacerbations. Starting at the top of this slide, we have the non-exacerbation, but COPD-related mortality, and we applied those standardized mortality ratios that are presented in this table and multiplied those by the age and sex-adjusted all-cause mortality to capture that increased risk of mortality patients with COPD experience that aren't related to an exacerbation. And at the bottom portion of this slide is how we accounted for the increased risk of mortality associated with a severe exacerbation. So we applied a case fatality rate of 15.6% per severe exacerbation. Next slide. For treatment costs, a price is not yet known for ensifentrine, and thus we assumed a placeholder price of $18,000 per year. For current maintenance therapy, we assumed an annual cost of around $3,500 per year based on a basket of drugs of LAMA only, LABA and ICS, and LABA-LAMA ICS regimens. Now, the basket of drugs within the current maintenance therapy was not based on the trial, but rather a retrospective cohort study that used US claims data of maintenance therapy regimens that COPD patients were on. And so we included maintenance therapy regimens with at least 10% of the population reported being on from that study. So that's why LABA-only drugs were not included in this basket. And also this study was conducted around the years 2013, so that predated the LABA-LAMA combination drugs. Next slide. All right, now we'll transition to the results. This slide reports our lifetime model outcomes, focusing on the cost outcomes. I'll present the health outcomes on the next slide. But you can see, using a placeholder annual cost of $18,000 per year for ensifentrine, the intervention costs, or the cost to acquire ensifentrine, are obviously greater in the arm that received ensifentrine. But there were slightly fewer non-intervention costs, these resulting from costs associated with fewer exacerbations and those treated with ensifentrine. Next slide. Looking at the health outcomes, as previously mentioned, ensifentrine did result in fewer total exacerbations. You can see those estimates reported on this slide. And then that translated into more life years, quality adjusted life years, equal value life years for the arm that included ensifentrine. Next slide. When we look at this incrementally, ensifentrine added on to current maintenance therapy as compared to current maintenance therapy alone resulted in a cost per quality gain of $248,000 and a cost per equal value life year gain of $214,000 using that placeholder price of $18,000 per year. Next slide. We conducted a one-way sensitivity analysis to identify the model inputs that had the greatest influence on the cost effectiveness of ensifentrine. And when you're looking at this tornado diagram, those inputs at the top of the tornado diagram that have the Y bar, those are the ones with the largest influence. So you can see the ensifentrine exacerbation ratio, the severity distribution of exacerbations, and the mortality risk associated with the severe exacerbation had a big influence on cost effectiveness. Other inputs that had uncertainty assigned to them, but had less of an influence are at the bottom, one of which was the annual maintenance therapy cost. Next slide, please. We conducted a probabilistic sensitivity analysis to identify and to estimate the probability of being cost effective at commonly used cost effectiveness thresholds. And so at the assumed placeholder price for ensifentrine, which was again $18,000 per year, we found that 12% of the 1,000 iterations within the probabilistic sensitivity analysis resulted in incremental cost effectiveness ratios beneath $150,000 per equal value life year gained. Next slide. We conducted a variety of scenario analyses to test the robustness of our findings and to test certain key assumptions that I've spoken to. From the modified societal perspective, the incremental cost effectiveness ratio was similar to that of the healthcare sector perspective. In the column that says exclusion of unrelated costs, this is where we excluded any non-COPD cost, and that resulted in a more favorable cost effectiveness estimate than our primary analysis from the healthcare sector perspective. And that incremental cost effectiveness ratio was around $190,000 per equal value life year gain based on that placeholder price. And then the scenario on the far right is when we assumed that ensifentrine did have an effect on that day-to-day quality of life, even when an individual is not experiencing exacerbation. And so when we made an assumption to include that treatment effect, the cost effectiveness improved to $175,000 per equal value life year gained, again, still using that placeholder price. Next slide. As I've already mentioned, you're probably sick of me hearing a price is not yet known for ensifentrine, and thus all of our analyses use a placeholder price. This slide reports ICER's health benefit price benchmarks for the price needed to achieve certain cost effectiveness thresholds. And so that health benefit price benchmark ranged from around an annual price for ensifentrine of $7,500 to around $12,700. Next slide. I want to touch on a few limitations, one of which is the evidence to inform the treatment basket for maintenance therapy predated the LAVA-LAMA combination products. And so this might be a limitation you all are concerned about, that basket might not have been representative of what's actually done today. Importantly, though, regimen and even treatment-specific evidence for the current maintenance therapy was only used to inform the cost of that current maintenance therapy basket, that estimate that was around $3,400, $3,500 per year. Now, we acknowledge this as a limitation due to available evidence, and to account for this, we varied the cost of current maintenance therapy across a really wide range, I think from around $0 to $15,000 per year. And then we use that in our one-way sensitivity analysis. And that variability in the cost of the current maintenance therapy had a very small impact on the overall findings, and ensifentrine added on to current maintenance therapy. So largely that cost is included in both arms throughout most of the model time horizon. The second bullet here, the modified societal perspective may not fully represent the impact of COPD on patients and caregivers. The current modified societal perspective did include patient productivity and caregiver time spent caregiving, but data on other indirect impacts such as caregiver quality of life were not available for inclusion. Next slide, please. We are grateful for the number of public comments we received. I want to highlight a few of them here. The first of which was a recommendation to use the GOLD ABE classification to define the health states in the model. Now, the health states in our model were defined by the GOLD classification, which does consider lung function to define disease severity and disease progression. There are newer classifications like this GOLD ABE classification that factors in both symptoms and exacerbations to classify the patient's severity. Now, these newer classifications are primarily used for guiding treatment recommendations, but the underlying severity progression largely remains the same. We chose to use the GOLD classification to define our health states due to the vast amount of data for transitions, costs, and consequences that were stratified by those GOLD classifications. We don't anticipate dramatically different findings if a different classification was used. And that's because the differential impact of ensifentrine that was modeled was primarily on exacerbations and not on disease severity or progression. The middle bullet here was a comment that encouraged us to allow for exacerbations to impact disease progression. We had a number of conversations about this throughout our assessment. We ended up not assuming that exacerbations affect disease progression, and this assumption was aligned with the majority of economic models in COPD. We are aware of a few economic models that have incorporated a reduction in FEV1 following an exacerbation, but most of those models were modeling FEV1 decline over time rather than modeling defined health states. We did engage with economic experts who had previously incorporated this link between an exacerbation and lung function and heard from them that the evidence to support this was limited and it was not a key driver of their cost-effectiveness assessments. And the last one I'll touch on was a recommendation to incorporate an effect of ensifentrine on day-to-day quality of life in the base case. Data on the impact of ensifentrine on quality of life while patients were not experiencing an exacerbation. We've already had a good conversation about that already. The evidence was mixed. We requested this from the manufacturer, asking for the impact of ensifentrine on quality of life while patients are not experiencing an exacerbation. We requested this and we didn't receive that. So because they weren't provided, we left assuming the improved quality of life associated with ensifentrine was the result of fewer exacerbations in alignment with other economic models. Next slide, please. And to conclude, treatment with ensifentrine results in fewer exacerbations and in greater quality adjusted life years, equal value life years, and life years. At a placeholder price of $18,000 per year, ensifentrine would exceed commonly used thresholds. Now, if ensifentrine is shown to improve the quality of life, that day-to-day quality of life and improve daily impact of COPD, even when an individual is not experiencing an exacerbation, cost effectiveness would improve. But at a placeholder price of $18,000 per year, it still remained above commonly used thresholds. Next slide. And with that, I look forward to the discussion.
Okay, I guess we'll start with Tim Will.
Thanks. As usual, the modeling reports by ICER group are really clear, transparent, and excellent. I want to thank you guys for what you do. Thanks. Couple comments. I would encourage both the use in the modeling and as we think through how we're going to discuss this, the term standard of care and what is the comparator group, because I think many of us are concerned, and part of your model suggests that those are some assumptions. Not only was LABA/LAMA, depending on your A accent, not widely used in these studies, but many of the patients didn't have any therapy at all at baseline. And I think any of our comparisons and wondering about your models really have to take that into consideration, how we frame the question and how we might frame the use of these drugs. Did the studies, a lot of your assumption is based on the risk of an exacerbation based on baseline FEV1 as defined by moderate severe. Did the studies ever break out a moderate versus a severe exacerbation, and therefore the impact maybe also on your models and on the post-exacerbation quality of life? Because those appear to be some of the major drivers in benefits and cost benefits.
Sure, yeah. So there was a lot of available evidence on looking at exacerbations per year, total exacerbations per year by COPD severity. We found that there was more evidence for that using the GOLD classification rather than the GOLD ABE classification, which is why we chose that to define our health states. There was evidence that looked at total exacerbations per year, and then evidence that looked at the relative percent that are moderate and severe. I always think back to what is driving these cost effectiveness findings. I understand all of these inputs are uncertain and variable, and I appreciate cost or sensitivity analyses to be able to account for those. But given our treatment effect we modeled is on the exacerbation, on the total exacerbation, that's going to what could be have an influence on the incremental findings. And so I think we had heard from clinical experts in the previous discussion.
But that's based on standard of care, of which I think there's some concerns of whether that's truly standard of care, or at least in those studies.
Sorry, just Tim, you want to be thinking about the model versus the trial. You can believe that the trial, because it didn't have appropriate standard of care, didn't look that you may or may not believe the relative effects. I think there's actually a lot of reason to think the relative effects probably do apply, in that we're not seeing a lot of effect modification there, but certainly fair for people to go, we don't trust that. In Mel's model, she's using data on what therapies people really seem to be on in the real world. Again, that may not be exactly what GOLD says they should be on, but it is at least what they are on in the real world. So that's not what happened in the clinical trial. It's what the background therapy is that she was able to find.
Yeah, I agree, but it may not be how we apply it to our future conclusion. Thank you.
Okay, Don.
Dr. Whittington, again, thanks for great work and with your team. We appreciate it as always. I think there may be some concern about the patient-reported outcome measures used here, and I'm wondering if you could provide a general sense in a qualitative way about how or if the measures observed in the studies influenced your calculations. I'm just curious about that connection, knowing that obviously the exacerbation rate played a major role, but could you just make a sort of a thumbnail guess about the influence of those measures?
Yes, the only treatment effect assigned to ensifentrine on any outcome was on that total exacerbation. Now, then exacerbations had downstream implications on mortality and quality of life, but it was only that 0.6 that was of it total exacerbations that was different between both arms. In our primary analysis, we did look at that scenario analysis that was, if evidence does suggest that ensifentrine improves that day-to-day quality of life that we've already heard throughout this meeting, then the cost effectiveness would become more improved, and we could incorporate that quality of that utility improvement. But the evidence was too uncertain, we didn't receive that evidence, and so that did not make it into the primary analysis.
Thank you.
Thank you.
Jimmy.
Hi, Dr. Whittington. I was wondering if you could elaborate in severe exacerbations, what a hospitalization entails. Is that an emergency room visit, or is that a scenario where a patient calls up their pulmonologist and they, send them to the floor of the hospital to get some nebulizer treatment?
That's a great question and an important context. I'm going to defer that one to my ICER clinical colleagues or our clinical experts, if that's okay.
I think we could ask the pulmonologist this, but in general, we're talking about admission to the hospital where people are getting a lot of nebulizers. They may get admitted to the intensive care unit. They're getting oxygen supplementation being monitored very carefully. They're getting systemic prednisone, systemic steroids, either as oral prednisone or by IV solumedrol, and they're given antibiotics. I just want to make sure before I stop there that Dr. Christensen doesn't disagree.
No, can you guys hear me? Okay.
Yeah.
Okay. I would just say, I totally agree with you. It can be very varied. And in fact, even since COVID, where everybody was afraid to go to the hospital, and I think that has continued, that some of our severe exacerbations are now classified as moderate exacerbations because people don't go in because they're nervous. But then you can get it all the way to people staying in the hospital for weeks because they're still not getting better or needing non-invasive positive pressure ventilation in the ICU for a while, and then go out to the floor for a while, versus some people can get better, you know, or they can get better enough to leave the hospital in a few days. That said, I think there's a little discussion in the chat here about what post-exacerbation life looks like. And that can be that people have symptoms for weeks and months on end, or even like this happens a lot where they're like, I feel fine. And then you talk to their partner and they're like, they're not fine, or I feel fine, but to be fine, now they can only walk a block as opposed to they used to be able to walk multiple blocks. And there's also, once you've had a severe exacerbation, there's really large risks of really increased risk of mortality. There's also really increased risks of cardiovascular events and strokes. So, so there's actually a lot that can happen once you've had a severe exacerbation that can look, that I think I try to teach my hospitalist friends and my patients about too, that I'm like, there's a reason we want to prevent these. There's a lot of bad outcomes that can happen.
Because I'd imagine where you receive that care, either in the emergency room setting or on the floor of the hospital, prescribed by your pulmonologist, could severely impact the economic analysis. So that's why, you know, I was curious to know, maybe it'd be better to break it down a little bit, but wanted to, you know, understand more about it.
And clinical team, correct me if I'm wrong, but we didn't have evidence for ensifentrine on the relative difference on severe or moderate exacerbations. And so thinking about the estimates reported here, it really is on the total, and then everything's downstream of that. So we didn't assume a relative difference on the severity of the exacerbation.
So just though, I think, Mel, for the non-economists, you're probably using some average total cost of a severe exacerbation that bundles all that stuff in and doesn't split out the ER versus the ICU versus the floor, that somebody has figured out what an average cost is. And because you're doing it across a large population, it doesn't matter, even though any individual patient might cost a lot more or a lot less. What you were just saying, though, I think, is that if ensifentrine, for instance, among the severe exacerbations was causing them to be less severe, we wouldn't have a good way of picking up the cost among that. If it caused fewer ICU and more hospital bed, hospital floor exacerbations, the way you modeled that wouldn't have picked that up, but we have no data that that's happening.
That's exactly right. And that's why I love the tornado diagrams. If you look at the tornado diagram, the cost per moderate exacerbation and cost per severe exacerbation, they're in there. We varied it across that big range to account for that variability. And it didn't really impact the cost effectiveness of ensifentrine because there wasn't a specific treatment effect on it.
Those are good points. Thank you. David.
Yeah, thank you for great presentations. And I have two questions. So one, you mentioned that in your model, you assumed the effects of adverse effects only on the treatment cost, not on the health-related quality of life associated with adverse events. And when I look at the table 8 in the evidence report, which is actually shared the reasons why patients actually withdraw from the trial, the adverse event, reasons for the adverse event is actually much higher among those who receive this treatment. So 10% versus 1% among those who withdraw from the trials. And then Enhance 2 report 14% versus 8%. So I think this incorporations of potential quality of life effects associated with this adverse event might have some effect on the overall ICER estimation. So that was my first question. Second question is on the modified societal effect. So in your modified societal perspective analysis, the ICER actually increases, which means that you're probably capturing cost associated. There are like added costs on the society, but you're also missing out some benefits outside of the healthcare sector. So I'm not clear that whether it's a fair representations of the societal analysis while you're capturing, cost to the society, but not really capturing benefits to the society?
Yeah, thank you. I'll take the societal perspective one first. The reason why the incremental cost effectiveness ratio does slightly increase, you're right, is because there is life extension in the ensifentrine arm, and then that is associated with a more caregiver impact. We looked extensively and asked stakeholders for evidence on how an exacerbation impacts caregiver time spent caregiving, because this is really an exacerbation model. Everything, ensifentrine is impacting exacerbations, and everything is impacting things downstream of that. We didn't have any caregiver evidence for how that time differs, whether you're experiencing an exacerbation or not. And we heard from stakeholders, it could go up or it could go down. If they're hospitalized, maybe that's a smaller caregiver burden. I don't know. I would love to hear from the patients on this. Or if they're not hospitalized, then it's more caregiver burden. And so there was not good evidence to suggest a split of caregiver time based on exacerbation. And that's why those numbers do go up, because the life years are greater in the ensifentrine. The first one related to adverse events. I'd love for my clinical colleagues to jump in here as well. I can confirm we did not assume any cost or quality of life associated with those adverse events. It's relatively typical in our modeling to only assign that for grade 3 or higher, pretty severe adverse events, and that didn't seem to be necessarily the case here, but this is probably an assumption that would favor the treatment by not assuming any cost or quality of life associated with those events.
Tim McBride.
Thanks. Yeah. Just a quick question. And given the nature or the size of the results, it probably doesn't matter that much, but because the numbers are so big. But I'm just sort of wondering, we had a pretty rich discussion in the chat, especially about the sample design and the way the sample looks on demographics. How does that play into your modeling? Do you assume the same sort of rates across different demographic groups? And
Yes.
Would it just affect it might affect the errors in the estimates probably, and we might just have less precise estimates for some of those groups if they're smaller.
Yeah, I can speak to how we accounted for it in the model, in that we don't do any subgroup population analyses in the model. So we use that 0.6 exacerbation, we modeled the average patient, and we get the average effect, and then an estimate of what an average value-based price would be for that. And so there are no distributional effects that have been incorporated.
Nothing modeled. And okay, thanks.
Okay, and Valerie, looking forward to your perspective. You've been putting a lot of good perspective in the chat, so I'm happy to hear what you have to say.
You're on mute.
You're muted.
I think it's really important to remember that exacerbations are not a one and done. I mean, exacerbations can affect our life for 6 months or longer or permanently. Once you have a really bad exacerbation, whether or not you go to the hospital, it might mean the difference between, like me, not needing oxygen at rest to needing oxygen 24/7 for months or longer. And it's actually a major change in life for me to have to always get my oxygen, make sure I have it, and always have my husband help me, because when I don't have him help me, it requires me to use more oxygen. And like when we were at ATS and I wasn't having an exacerbation, American Thoracic Society, I wasn't having an exacerbation, but walking long distances because I had recovered from an exacerbation in February, and this was in May, I still couldn't carry things and use oxygen and walk long distances as before I could. And I'm not sure I will ever regain that ability. And my husband sure wishes that I would, so that I can carry stuff and walk. But now it's like, I'm sorry, I'm helpless, because otherwise I need more and more oxygen and we run out of battery. So I think you can't understate how long the tail is from an exacerbation. It can be 6 months or longer. And some people just permanently are at a new lower level. that they can never get back to where they were. And that's the stepwise problem.
That's really important context. And one reason why I always appreciate ICER bringing together all of the stakeholders to provide that story alongside a cost effectiveness analysis, because we can't capture all of that in a cost effectiveness analysis. And so we do have to consider things that are not quantifiable. This probably gets too wonky on the health econ side, but this is something that I love of why we chose to model exacerbations as events rather than as a health state is we have a lot more flexibility on how we don't have to state how long an exacerbation is going to impact. So we had an annual cycle and we assumed a disutility that was annualized over that entire cycle. If we were to model as a health state and then we set our model cycle, then we'd have to only have that disutility for that cycle. And so that was one decision that went into one factor that went into our decision making of having this be exacerbations be as an event, because we understand that the consequences could be variable, they could be long, and there's not great evidence on how long that lasts. Thank you for sharing that.
Yes, thank you very much. And our last comment or question will be from Phyllis. Thank you.
Yes, I just wanted to add my opinion on the focus on exacerbations. They are such a big part of our lives. They affect everything, not only our spouses, our caregivers, just the whole mentality of dealing with an exacerbation and not getting back exactly where you were before and not continuing with your activities. It impacts your mental health as well. So, there's a continuum of costs and healthcare utilization whenever there is an exacerbation in much of the COPD population, in my opinion.
Thank you. Thank you for your comments. At this time, we're going to move